Ruchi, hi, and thank you so much for joining me on Faces of Digital Health to talk a little bit about startups in digital health. How can they go into different markets? What are the differences that we see globally? You have been in many, many roles in the past, from policy. You have a medical background. You work with companies. So let's start with maybe just your short reflection of everything you've done so far and which roles were potentially stood out most so far, or any interesting thoughts that you might have.
So first of all, thank you for having me. It's really exciting to talk to you. And I've seen the podcast series that you've been hosting with great leaders in the industry. So I was very enthusiastically looking forward to this one. In
Wonderful.
terms of my background, I think I've had a very unconventional career where I graduated as a dental surgeon, but then lost that to public health several years back. And while deploying public health, across 19 to 20 countries I worked in, I realized the importance of technology. And initially, I adopted technology just like every other physician for the sake of public health. But now, digital health, which was called M-health and E-health in those decades, has become pretty much mainstream. So now I work with some of the large startups and scale-ups, helping them get access to funding and scale in new markets. And that has been pretty exciting for me so far. In terms of memories, there are so many memories of doing things for emerging markets where frugality stood out in terms of, people not gold plating products, but still delivering immense value. So I'm happy to share more of that as we progress towards the podcast and questions, but very excited to be here.
Wonderful. Yeah, you definitely have a lot to share from the global perspective. But just going back a little bit to startups, it's been a while since I had discussions around go-to-market strategies. So I'm wondering, what would you say are the key shifts that we've seen in the last few years for digital health? We know that it's quite hard to scale, especially across Europe, due to different legislations. Another trend that has happened in the last few years is for business models to be sustainable. Software tends to be subscription based. Yeah, what are your observations in terms of the shifts, especially with the AI?
Yeah, so I think when it comes to global GTM, whether it's in the US or in the UK or the rest of the world, it has moved from what we call as promise to proof. And what I mean by that is workflow integration has now become very important. So usually I'm talking about EHRs. So anything which is a standalone app it's not something which is appreciated. The other thing is clarity around the budget owner or the reimbursement of the project has been very, very clear from a funding perspective and from the access perspective as well. So if you don't have a clear model of reimbursement, or if you don't understand your buyer completely, you might be in a state of limbo. And third is obviously around the clinical efficacy and the regulatory part of it. So if you are not, there from a safety and efficacy angle, it can become a big hurdle to your GTM. So regulation has pretty much become a part of GTM rather than just a compliance check. So I think that is probably the biggest shift that I have seen of companies moving in. And um, I think also from a capital market perspective, there has been a funding reset in terms of what kind of companies are funded. And most of it is around evidence and ROI. So, evidence right from the clinical efficacy to the operational efficacy to who will be your buyer, how you'll get reimbursed, to what would be the outcome, and then the scale. So, once this trajectory is clear, GTM and funding both become easier. But if it is not, then it still remain high on promise but low on proof.
Hmm. Do you see that companies often don't have the right understanding or idea about reimbursement? Because if I think of startups, when they are in contact with VCs, they have to have clear business models. So do you see that, I don't know, business models aren't thought through, or that they're based on wrong assumptions? Can you go into that a little bit deeper? In MedTech Malta, one of the things that you said was also that startups should make sure that they stay investable, which I thought was really interesting because it's easier said than done. So let's go into that. So realistic business models, sustainability, long-term runways and roadmaps.
Yeah. So I think you rightly noticed that. I think that is probably something which was highly appreciated as a takeaway of that particular debate and panel discussion we had. When I say staying investable, I basically mean de-risk your path to scale. And um, and that usually happens when you think of these four pillars in conjunction to each other, right? And this is very, because I'm an angel investor as well. So this is a very angel investor or VC way of thinking. So first is the buyer and the payment model, which we just talked about. If there is fuzziness around who your buyer is and what is the reimbursement model for your product, then your business is not investable, right? And if the evidence is not tied to money, so I talked about ROI when I spoke about the opening of this panel discussion. So if the evidence is there, for example, there is evidence that you can catch more errors than an X software, which is great. But if it is not tied to money in terms of who does it really help? Does it help a payer? Does it help an employer? Does it help a hospital system? And in that hospital system also, is it the CFO budget? Or is it somebody else's budget? So that clarity has to be there for your business to be investable. Otherwise, you will just show PowerPoint slides and show models where it will still be fuzzy for the buyer to understand how to reimburse these model or who pays. And I think one other statement that I made is the moment you say um, you pay for this, the adoption stalls, right? So it has to be very clear about reimbursement. I think the third thing that I usually talk about is repeatable deployment that not many companies talk about. So if the startup is not in the room, and that is a prerequisite to scaling a product, then your product become uninvestable, because scalable products can scale on their own. It should not have the dependence on that startup who delivered that product. And last but not the least is the regulatory angle of it, right? So think of this. If your product takes 9 months for every hospital to adopt, then your hidden cost of acquisition makes you uninvestable. So you have to lead with evidence, lead with the buyer mindset, the reimbursement model angle, and de-risk yourself regulatory wise as well to remain investable in this market, because that's the most low friction path for adoption and scale for you.
Hmm. I think that the whole question around the return on investment has become a little bit unclear with AI, meaning that we definitely see a lot of theoretical potential, same way as we did in early stages of digitalization when it wasn't yet clear what are the side effects of innovation. We weren't aware that, doctors are going to be burnt out, that there's going to be alert fatigue with clinical decision support systems, etc. And similarly with AI, the big question at the moment is how can hospitals measure their AI strategies if they even have one? So how do you see that? Do companies actually have results around the improved clinical safety, work optimization, and to which extent are these more theoretical than practical?
Good question. So I think we need to break it up into two. So one is the clinical part of the AI systems that we are talking about, and the other is the operational part of it. Now, I think the regulations have been very, very clear about the clinical efficacy and safety part of it and the risk classification part of it. So there, I think there is still a lot of information available for companies to comply to and prove that. But when it comes to operational ROI, which basically means workflows optimization or reducing claims or readmissions, and that part of the system, that is where some product owners might think that they will have X level of impact in terms of ROI, while the system buyers might not feel that way. So I think one maturity that has to come across all GTMs, across AI in healthcare, is for you to think what works for a healthcare system and not for your product, right? So think of your product in that pathway, in that clinical operational pathway, and then say, what am I really optimizing for? Am I lowering cost? Am I making a faster throughput? Am I reducing claims? Am I reducing readmissions? What exactly is the efficacy that I'm bringing into the system? And then go to the quantum of it. Now, sometimes in healthcare, we have disparate systems. So there is interconnectivity challenges, interoperability challenges, and data challenges around proving ROI. And that's why most of the highly funded systems that you will see that are on the horizon right now and are getting investable are, you take one system problem, one solution, one ROI measurement, and you prove that before you move into the whole system-wide deployments and then trying and struggle to prove ROI of those systems. So I think we have moved very well when it comes to the clinical part of it, but when it comes to the operational part of it, people still struggle to justify the ROI, the impact, the cost part of it. I think that is where things have to improve.
Mm. Oftentimes, we also like to say, especially when it comes to EHR or complex software systems, that the implementation is almost more important than the product, because two organizations can use the same product, but the levels of satisfactions are going to be different. The results are going to be different just because the buy-in is different or the culture is different in different countries. So maybe we can go back to that question of products needing to be self-scalable. Is that more referring to the direct-to-consumer products or also to enterprise solutions?
So enterprise solutions as well. So let's look at US, for example. You have to sell to the mindset, right? You have to sell to what they really value. And it differs from market to market, can also differ from establishment to establishment, because even US is pretty fragmented a market, and rules and regulations can also vary from state to state. So in US, it's always around labor and utilization, right? That's like the key thing, the key mindset that you have to sell to. In UK, where I am based, it's more around capacity and waiting list, because that's like the biggest problem here of capacity and those backlogs that exist all across. And for payers, it has always been total cost of care. So whenever you make your product and you are choosing one of the buyers as to be your ultimate anchor buyer, think of these things in terms of what you can deliver in terms of an ROI. You need to remove the friction first, get them to adopt something. And, one analogy that I always give is that if you create one more step in a clinical workflow, right, you need to offset it with a metric that is useful for the system. Because if you're adding more cognitive points for a doctor to, and they already have paucity of time and they're doing 100 things, they might not like a lot of information that you think is useful for the patient or for the doctor. So you need to create a tangible outcome of why should they go for that extra workflow in terms of an ROI. And if you feel that, only after 10 or 15 steps will you reach that ROI that you're planning to progress to, again, you're talking about cognitive overload there. And it might not get the adoption that you are probably looking for. So I think you need to play to the mindset. Everybody has a very different physics when it comes to these implementations. So you need to target that.
Yeah, absolutely. It goes back to the challenges between innovators doing or creating solutions that in theory are useful, but they're not exactly usable, so they're not used and are useless in the end, in practice. Just emphasizing the importance of UX as well. If we go to trends in the last few years, especially with AI, in 2021, you co-authored a paper about artificial intelligence in health policy, where you talked a lot about responsible AI, the need to be transparent, to make sure that privacy is respected, that the societal benefits are there, that we have clear accountability, etc. So, based on your observations of solutions that you see in practice and also the things that are implemented, how would you say we're using AI today from the point of view of responsibility?
Yeah. So I think privacy is definitely improving. And from 21 to 25, though it has been quite a lot of time, but not much has moved towards establishing proper system for operational AI. So clinical efficacy, as I said, I'm not too much worried about. Privacy is improving as well. But when you talk about transparency and accountability, those are still very big challenges that occur. And as much as, product companies wrap it around saying, this has been taken care of, it's mostly on papers and less in actual. So clinicians and patients still don't know which AI is being used, what is it used for, and how good it is. On the other hand, you know, um, the systems or the algorithms that you're using, um, they might not have full regulatory approval, especially algorithms that improve over time. So systems that basically learn from more and more data, adapt and change the algorithm over a period of time. And because there is not a longitudinal study of those, this is not a life cycle exercise. It's like a tick box. Okay, fine, this works, let's go in the market. The accountability also becomes a big challenge. So for example, if I'm in an operation theater and anything goes wrong with AI that is guiding me, whose responsibility is it? Is it of the hospital? Is it of the vendor? There is still a lot of fuzziness and conflict over there. So that has not changed over the years. And I would also mention bias. So algorithmic bias exists. And sometimes, even if the system is accurate, but it's placed inside an environment where, workflows are biased or there is non-equitable access, it can still give and amplify inequity in healthcare. So that definitely exists. What I have provided is a framework. If you are a hospital or a health system, how to look at some of these AI products, what to have a checklist for, so as to be as safe as possible. But nothing can take over a longitudinal study of these products as they stay in the market, continue to evolve, and to see what kind of feedback or what kind of outcome is happening on the ground, and then reevaluate the system. I think that life cycle is missing right now.
Mhm. Given your focus, on ethics and responsibility, are you concerned about the introduction of AI from the perspective that it's going to be very hard to find out and unveil any bias and the impact AI might have on different populations because, hospitals don't really share their data or maybe don't have time to do research? Most the entities that could do research are healthcare companies providing these solutions, but it's a big question if they would be willing to share that data publicly.
Yeah, you're right. So interest, incentives, they vary from hospital to hospital, place to place, political environment. And that's where regulation has a very big role to play. It should not happen, all this due diligence, just at the time of procurement, but at the time of regulatory approval. Because once it is in the market, how it is being used, how it is being deployed, and what is the outcome that might not be visible to the regulatory bodies up until a certain period of time. And in healthcare, privacy and evidence has always been very important. We always wanted predictable healthcare because when a patient comes to you, he basically asks you this question: what is the probability of me getting well? Or what is the probability of things going wrong? And being a doctor or being a physician, you have to very openly and transparently answer that question. But if you are in a limbo yourself and you don't know what AI has been used, how good it is, if it is a black box and you do not have access to half of the things, then it is very hard to assure somebody, and it could be a false assurance as well. So there is a very thin line between medical malpractice and medical error, and that a physician has always to be mindful of. And that's why the adoption of AI in healthcare has been so slow and so conservative over a period of time. But yes,
Mm.
if at the regulatory level this is checked, then there are lesser chances of this going out of hand at enterprise level.
I've never thought about this before. It's, we are really trying hard to make things predictable in healthcare and expecting the tools to be 100% accurate. But at the same time, when it comes to an individual, each person is a black box. So when you get a drug, it's basically let's try and see what happens. There's no guarantee that something's going to work. In immunotherapies, you have 1/3 of patients for a specific indication that are going to be eligible for a specific drug, and then 1/3 of those are going to respond to that specific drug. So, yeah, that's just a consideration. I don't know if you have any additional thoughts around that, maybe mostly around managing expectations around
Yeah.
accuracy and what technology can do.
So the right leaders do everything which is right, balancing access and equity. So they would tell a patient how much ever they know. They would be responsible as a governing body or as a clinical body within the system for the right adoption of the right kind of tool, the procurement, the vigilance, and the due diligence part of it, and then overall outcomes over a period of time. But not everybody is sitting at that level, high up there to have a say in the decision making. And that's where I say regulatory and today there are various methods to do this. There are sandboxes available. You can sandbox the technology, still get a live environment, deploy it and see its outcome before you do a nationwide deployment. So regulators have adopted some of these things. They have also done a certain data set study. But, just like any other technology, the differences in outcomes, the differences in satisfaction levels could always be very, very different. So we have to be a little less harsh towards AI, but at the same point in time, make sure that, there are no blind spots that we are leaving behind because it can actually cost a life.
Yeah, that's the tricky part, which is also why any AI solutions related to healthcare under the EU AI Act fall under high risk
Yeah.
category and are therefore highly regulated.
Yeah.
Um, I want to move to a broader global perspective on technology and AI. You worked with several organizations from the UN, WHO, and health interest groups in the past across India, Africa, Middle East, Europe. So you definitely have an idea on what the different markets look like. Do you have any memories, any anecdotes of either projects or countries or leaders that really inspired you or that stood out to you, or stories that you think the audience hasn't heard before?
Yeah, so as I said, I am one of those grateful people that got an opportunity to work in several markets and learn, whether it's large development banks or bodies like WHO and UN. I got to sit on some of those committees, write certain frameworks, and also talk to people who really matter at the top. I think the dynamics are very different across different countries. So, for example, in Europe and UK, it's more around trust and regulation. So things will be slow, things will take time, but the things will be fantastic once they get into the system and they go live. In India, it's more around scale and national platforms. You think about the national IDs, the Aadhaar layouts. It's extraordinary at a volume, the size of the country. When it comes to Middle East, it's more about ambition and capital and speed. So politically, there is pressure on creating better systems, bringing in AI into the system. And because it comes from up top, things are very, very quick. Especially in Saudi, I have seen things are very, very fast when it comes to the table to when it goes to deployment. And then Africa. So there also innovation works, but in a very resource constrained way. So on the last mile, you will see extraordinary innovation, but because of resources, because of less capital, because of fragmentation across things struggle because it's considered to be an emerging market. So when I worked with Tech Emerge IFC, which is a part of World Bank, across 3 markets, which was India, Brazil, and Africa, I realized that they have the most practical framework when it comes to deploying innovation in different markets. So it's always starts with a product market fit, right? And then it starts with which stakeholders they benefit from. So they just don't bring a product because it's a good product. There has to be a clear buyer on the ground saying, yes, I understand the problem you're solving, and I want to solve that problem in my enterprise. So let's do a pilot together. And then a very clear commercial model, right? From regulations to partnership to data governance to the commercial model for them to gain success after the pilot is over. So not that purgatory pilot talk where there's a pilot that happens. And I usually say this digital health has a problem of pilotitis. So once the funding runs out, the pilots fail and the adoption never happens. So the technology, which is AI driven today, doesn't have to be brilliant, but it has to be boringly efficient, right? And it should have a clear buyer. I think that has been a takeaway across markets, but the mindset has been very different, and the way things and innovation moves has been very different.
Mm, it's one of the thoughts, around pilots and why we do so many pilots and why things don't go beyond pilots. A thought I heard at Health Tech Portugal last year was when one of the policymakers said, we do pilots because we don't have the money to do the full scale implementations. I don't know if you have any comments on that, if you agree or disagree.
Well, of course, everybody has money, but everybody does not have the right dialogue to put forward. So everybody in the stakeholder value chain, right, has to demonstrate something to get funding. It's with everybody, right? Even if I go to a conference today, I have to ask my CEO or my board saying, this makes this ROI sense for me to go forward. And I'm confident about that. So would you pay? And then they would. Right. So there is money sitting. There has been, but there are no approvals. And there are no approvals because there is no significant ROI proved. And even these pilots, the design of a pilot has to be very important. I have seen pilots, and that's why I appreciate Tech Emerge so much, because a lot of brain power has gotten inside, and some of the best leaders were on the advisory board with me to create some of those frameworks. A pilot has to be designed in such a way that it's a very non-friction way of getting into commercialization once the pilot is over, if it has, certain metrics matched. Most of the time what happens is pilots happen because the product guy want to prove something, and that might not make any health system sense. So there is input from one side in terms of brain power, but not the involvement from the other side. So even if the pilot do good, it's good for the product guy to just have another publication saying this worked, but a health system didn't gain much from it or didn't get the viewpoints they were looking for to make it commercially viable for them. And so the
Mm-hmm.
funding didn't happen. So it is very important to design the pilot in such a way that once a pilot is successful, commercial adoption is just a natural progression.
Yeah. So basically, maybe we should rethink the quality metrics that we
Yep.
set for pilots.
Yep. And it is very hard. I would say it's, as you said, it's easier said than done, because not many people understand a physician and then understand the technology and then understand the regulatory part of it, and also have the financial acumen to think like a CFO um, for that AI adoption to take place within an enterprise or on a national level. And it's because we do not study healthcare as one ecosystem. We are specialized in fragmented parts of it. And though everybody has a say, to converge those thought and get to a certain kind of design thinking has been very, very difficult. And only a few companies actually invest in design thinking to design something like this.
Mm. Given that you have the global perspective and understanding of different markets, and you're also an investor, I wonder if you what kind of impact do you observe on different kind of geopolitical tendencies and ambitions? On the one hand, we've got large rivalry between the US and China. Anytime I did sessions or interviews around innovation in Africa, it's like 80% of the time innovators either come from abroad, either live between the US and Africa. So I'm wondering if you maybe also see any Chinese influence given the interest China has on Africa. And then at the same time, I'm surprised how very little do we talk about India. Maybe that will change now that the EU has made this huge trade agreement with India, which is gonna
Very
turn
excited
into
about that.
quite. Yeah. So tell me more about your expectations, your thoughts about how basically capital moves and impacts how healthcare is developed in terms of innovation in different places.
So, okay, let's think about three perennial problems that health systems continue to face across the globe, right? Let's not talk about emerging markets or developed markets. It's pretty much the same everywhere. So one is that everybody wants simple solutions, right? So that is something which I call as reverse innovation. So a lot of what we did in India or Africa or Brazil was taken back in the US, in the UK and European markets to learn from. So how simple solutions can be without any gold plating, pretty frugal, easy to understand, easy to digest it by the last mile worker as well, and can bring in those benefits. So simple solutions is the first key thing. I think second is workforce shortages. People feel that in emerging markets there is workforce shortages or lack of skilled labor, but it's the same here in the UK, it's the same in the EU, and it has been the same in the US as well. So solutions that by design create more value for everybody without creating more dependence on office visits or face-to-face doctor appointments, and can manage diseases through remote monitoring or through telehealth has always been the key, especially when you look at it from a population health or a public health perspective. And I think third thing is um, clarity around how to make it viable, right? So some solutions can work in certain economies for a period of time, but they might not have the financial backbone behind it. So most of the solutions are a health tech, fintech, um, combination that I see coming in emerging markets because they do not have systems where finance is totally separate to what the healthcare innovation is. They do not have a financial backbone either. So they are now bringing solutions together, health tech, fintech together, and then going out in the market. So I would say that if I had to invest in any of the companies, first I look for is evidence and ROI. That is very, very important. And even if it is not proven yet, I want to understand the founders' thinking around what is the problem statement they understand is big enough for them to solve, and how will they continue to solve it without having a huge CAC or a customer acquisition cost. So uh, if the solution is simple enough for everybody to understand, there could be a public health angle to it. And I do invest in those startups as well. I know a lot of VCs probably do not invest in such startups that have a public health angle or a population health angle, but I do because I feel that sustainability and success, they are not opposite to each other. A business can be sustainable, can be frugal, but can also be successful, right? And more VCs are seeing a shift. Earlier VCs in health tech, if you see, they always talk about growth, growth, growth. How many more numbers, what volumes, what scale? Now they are shifting towards more evidence, more ROI, because they know that until and unless in healthcare you prove this, any scale is very short-lived. You'll not be able to, replicate that over the years. So your growth will become stalled anyways. So they are focusing on next-gen leaders who understand some of these things, and basis that they invest in those people. Also, I feel that there are a lot of So when COVID happened, workforce shortages became globally relevant, right? And all of these models. So I created a health service in India. I'm talking about 2011-10 kind of a time frame, where you can call a doctor on phone and get a prescription, a valid prescription on paper with the doctor's registration number for $1. Right. And it was amazing for the Indian population, because back then we were seeing an influx of people moving from one city to another city for jobs, for technology, for, startups, and they might lose the ecosystem they have. So family doctors and, people that they know they can rely on for healthcare. And if your child is crying in the wee hours of the night, who do you call? So we create a system along with Airtel, which is one of the largest telecom providers in India, where any mother, anybody can just call the system, tell about their symptoms. We have access to them and to how they feel, and they can get a prescription for $1. And the medicines they can either buy at the counter or can be home delivered from registered
Mm-hmm.
partners. That became
Mm-hmm.
quite a global, acceptance in the market in terms of how important it is, not just for emerging markets, but for countries like US as well, which is managed by, nurse stations, because there is a paucity in terms of the doctor's time available for them to check on. But in India, you have access to doctors because there are so many doctors, and sometimes they're living in areas where the influx of patients is not that much. So
Mm-hmm.
how do you do responsible resource allocation in such a way that patients get what they want, doctors get what they want, which is an earning, but you create a system in between that keeps the cost of prescriptions very low, but still make it viable for people to avail it outside of their insurance. So,
Mm-hmm.
some of those models are probably the key shifts in mindset that came in after I worked on digital health. And digital health at that point in time was very unheard of in emerging markets. It was more of a Western concept. But now I
Mm-hmm.
think we are probably the trailblazer when it comes to digital health.
Mm-hmm. What would you, is that system still live, by the way?
The system is probably live, but it's not in the same shape and form. It's not Airtel running it, because I think there was some discussion around a telco being involved in handling healthcare data.
There's definitely improvements with telemedicine, but also with AI, there's an increasing need for digital health or healthcare literacy, for people to know how to use these tools to help themselves in the increasingly strained healthcare systems. So, from the patient perspective, I worry about how that gap is going to widen based on digital capability of an individual. What about you?
Yeah. Um, initially when digital health came in, everybody said that, we want digital health because we want equitable healthcare access, right? So everybody started talking about digital health. Okay, let's have equitable access to healthcare wherever you are, whenever you need it, and digital health can enable it. But very soon, everybody came out of that misconception and realized that digital health does not create equity. Digital design does, right? So, what I mean by that is, on one side, we have seen a lot of digital health projects creating great ROIs, right? So, I talked about teleconsultation, I talked about AI triaging, I talked about remote monitoring, and this has creating significant ROIs. But on the other hand, if you see, it has created a lot of dependency on broadband or internet or digital literacy. So in UK itself, there are people who are not digitally literate enough, especially the baby boomer population. So it's very hard for them to get onto a digital health system if you digitize the entire system and say, okay, no phone calls anymore, no paper records. All we will do is through an app. They might not have the digital literacy. And then there could be bias and other things that are not there in a probably face-to-face or a physical consultation. So yeah, I mean, but if you create a design, which I'm talking about, where you created a system where you're not creating gatekeepers, right? It's not that you have to first go digital and then only you can see the doctor. But you design it in such a way that there is a human angle to it, there is a technology availability angle to it, there is an outcome measured by subgroups of people who are utilizing that technology. And then it goes back into the throughput of how to make the systems better. So digital health is a part of healthcare system and how healthcare delivery happens or health is availed. But it cannot be a gatekeeper, because if it is a gatekeeper, then you are kind of sabotaging a certain kind of population or a marginalized population, and that creates bias and not equity. So I always say that digitization doesn't create equitable access, design creates equitable access, and we should focus more on design than digitization.
Mm, I think the whole importance around design it has taken us a very long time, a decade basically, to unfortunately see on based on burnout how important the whole UX and design is for the end users.
Yes, absolutely. And it continues to evolve. I mean, I'm sure that once we are past this hiccup, there will be something else that will come in. So in healthcare, there is no sure shot answer that this particular platform, this technology would just solve the problem. There will always be a population that has been sidelined, or there's a population that has not been catered to. So the dream of equitable access stays. It's the pillar of public health and how we see the population benefits, but it's a long way to get there.
Mm. Um, Policymakers and innovators don't always speak the same language. And given that you contributed to health policy at organizations such as WHO and the UN, how do you think that regulators can better keep up with digital health innovation, especially now that, the innovation is really, really moving fast with AI?
Yeah. So, regulators don't have to outsmart innovators in any way. All they need is new learning systems. And I said initially that there are sandbox technologies available right now. If you look at the FDI AI framework, EU AI framework, or you look at the WHO's AI ethics, responsible AI framework. So you can have a good solution that you think could be beneficial for a certain part of population or population as a whole, to implement it on a sandbox in a live environment and see those results, right? Second thing, which
Mm-hmm.
I mentioned earlier, is life cycle regulation. So it's not just a gate tick box of compliance that, okay, you get in and then you do whatever, be a terrorist. You can't do that.
Yeah.
Right. So there has to be life cycle regulation of AI, especially for systems who become smarter and more efficient as they learn through data along the way. So there has to be governance there. And the third is real world monitoring. So there are patient bodies, there are entities on the ground that always report bad outcome, challenging outcomes, or outcomes that have a question or suspicion. You need to listen to those and improve your regulations and tighten the screws when it comes to such regulations. And make sure that you're not missing out on a certain parameter just to enable that there is more innovation and growth on the ground on the cost of governance. And it is a very hard balance, because too much regulation also stifles innovation. And less regulation can really be, bad for a certain population group, or can act in a very different way than expected, which can also lead to varied health outcomes. So it's a very difficult match, I would say, but I think that is the only way to go.
Mm-hmm. As we alluded to many topics, there's definitely no shortage of challenges in healthcare. We mentioned the challenge with the workforce. And as the last question, I wanted to pick your brain on advice that you might have for young professionals that want to enter or are in the digital health field. What kind of skills or mindsets do you believe the next generation of digital health leaders needs to cultivate? Especially Gen Z and Gen Alpha think very differently about the work-life balance. When we talk about AI eradicating jobs, it's the current discussion among leaders such as Demis Hassabis and others is that entry-level jobs are going to be most affected at the moment. So at the World Economic Forum, his advice was for everyone to get as literate and as skillful in the tools that are being developed to be able to contribute and be competitive in the industry. So what do you think? Are there any areas of knowledge that upcoming innovators should focus on to drive meaningful change in healthcare?
Yeah, interesting question. So, what I like about the new generation right now is how they see their life as a balance of everything, right? And they do acknowledge and understand that burnout is not a badge of honor anymore, not in healthcare and not anywhere else. And especially burnout, when happens at a clinical level, can create more unsafe systems than possible. So I think the new generation will be the translators in this world, where they will translate the regulations to the design, to the AI, to the economics, and to human behavior. And I feel that these people probably will have the potential to create everything from a design angle rather than from a just digitization angle. And I have high hopes for that. And I already see I have a lot of colleagues and even my cousins that I see how they look at life and how they create value. And I think that they are all mission driven, they are not martyr driven. And they understand that sustainability and growth can go together, and they are not opposites of each other. And they absolutely work towards building themselves around governance and innovation at the same point in time, which I think is the essential tool. And when I was growing up and when I was learning about things, one day you learn about product, and then you learn about innovation, and then you learn about marketing, and then you learn about 100 things. But regulatory perspective came in very, very late. And that's why I became, a policy advocate, and I did advocacy at global levels, because I realized that this part of the overall philosophy was just kept on one side. There are still organizations who feel that whatever FDA has designed, they need to just comply to that, and they need not have any cultural nuances fit into their regulation, so that the innovation should not feel stifled. But I think they need to revisit some of these values and tweak some of those governance solutions to match their regional footprints as well.
You mentioned that, in the end, you also started to learn about policy. Can you talk a little bit more about that? How was that? Like, were you super surprised? Was it a completely new world of perspectives that completely changed how you think about medicine and innovation? Uh, How was that?
See, I believe in human capability, and I realized that initially when I got interested about technology, especially in public health, I realized, oh yes, I cracked the code. No more truckload of papers, no door to door, and I can save so much labor. And I was absolutely excited by the potential of it. But then when we deployed technology, we realized that there were so many hiccups. To give you an example, people would not go door to door for, say, polio vaccination or other vaccinations. They will just go and they'll come back and they'll say, I went. In that technology, there was no GPS. Then there was an introduction of GPS to see he actually went there. And then the second hiccup come in is they go there, but they don't administer medication. They sell it off to some third vendor for profit. So then the tracking comes in terms of the vials and the cold chain, in terms of there is no theft there. So as and when you progress towards it, you realize that there are so many loopholes, and human mind is so smart to find some solution or the other in every way possible, that at a regulatory angle, you need to be much more stricter about some of these frameworks, the design, the process, and the implementation on the ground. So that whatever money you are being pushing into healthcare delivery, or to have more better outcomes in a patient population, you actually realize that after that input. And I realized
Mm-hmm.
that there were certain, for example, there were certain solutions that were already there in, say, Africa, which were not there in India at that point in time. And I thought that probably at a policy level, we need something like this. I also did one study with CII and Eli Lilly in India, where we realized that half of the population that they were saying as diabetic was not diabetic because the cultural norms was to eat a lot of food before you go to your farm. And if that time we will do a random blood glucose, it will obviously come high. But that doesn't mean that person is diabetic. It's just the way the life is. So all I'm trying to say is that whether it happens at a regulatory level or a procurement level, and then the overall policy level, we needed more and more people who are working on the ground, who understand what is not going right, to weigh in when the policy is being created. And when that came in, I think that led to the turning point in public health at a policy level, because all those people who were working on the ground, who were deploying some of these solutions, could just weigh in, the grassroots level learnings right at the policy door.
Mm. Well, Ruchi, thank you so much for taking time for a discussion for the podcast. I think this is one of those episodes that's so rich with content that you need to listen to it more than once to just kind of get all your points across. So thank you so much. And yeah, let's keep in touch for any future updates that you might have on your projects.
Thank you. I thoroughly enjoyed my time here. Thank you for having me.